Good evening, and welcome to the second lecture of the 2020 UTU season. Tonight we'll hear from Dr. Randall J. Olson and Dr. Gregory S. Hageman. I am Brooke Abel, coordinator of the UTU lecture series, and I will be moderating this lecture. If you have any questions for Dr. Olson or Dr. Hageman, please email clubs@alumni.utah.edu or comment in the YouTube chat throughout their presentations. We will address your questions during the Q&A portion of the event. It is now my pleasure to introduce Dr. Olson and Dr. Hageman. Dr. Olson is a professor and chair in the Department of Ophthalmology and Visual Sciences and CEO of the John A. Moran Eye Center. Dr. Olson specializes in research dealing with intraocular lens and cataract surgery. He is the author of more than 300 professional publications and has given many named lectures throughout the United States and the world, as well as received numerous awards for his work in ophthalmology. Dr. Olson just celebrated his 40th anniversary at the University of Utah and is believed to be the longest serving chair of any academic ophthalmology department in the country. Dr. Hageman is the John A. Moran Presidential Endowed Chair and Executive Director of the Sharon Eccles Steele Center for Translational Medicine. Dr. Hageman's primary research interest for over 30 years has been directed toward the genetics and biology of age-related macular degeneration, a leading cause of worldwide blindness. Dr. Hageman has twice briefed the U.S. Congress on his research findings and has received numerous awards for his contributions to AMD research. A major goal of Dr. Hageman's current efforts is to expedite the pace at which basic scientific discoveries are translated into clinically effective therapies for the treatment of AMD and its co-segregating diseases. Dr. Olson and Dr. Hageman, thank you for joining us.
Brooke, thank you. I want you to know that it's an honor for us to talk a little bit about what's happening at the Moran Eye Center, and in particular to be able to hear Greg and the amazing work he's done with macular degeneration. First of all, though, I'd like to have an opportunity to talk a little bit about the Moran Eye Center, what we're about, what we represent. So I kind of get the next slide, please. So we're the largest clinical care center in the Intermountain West. In fact, the largest, you have to go either to California or all the way to Michigan to have something that be of a similar size. So we have about 60 faculty members, 63 the last count, 10 satellite clinics, 15 research labs, over 500 staff that are involved in all elements of what we provide. So this is education. It includes postdocs, residents, medical students, fellows, as well as a very vigorous research effort, as well as clinical care. And we're able to provide subspecialty care in all of the different areas associated with ophthalmology. And that is also something that's unusual, that we have, all of that in one place that can cover everything from extremely esoteric to very common. Next slide, please. So 65 is the latest number. I was already off by 2. And you can see that we have PhDs. We've got a lot of MD PhDs. These are people both involved in clinical care as well as research. Fellows, those are those who are training to become subspecialists. So you finish your residency, you're an ophthalmologist, but you've heard people being a retinal specialist or a corneal specialist, glaucoma specialist. That's also an important training program. We have some of our fellowships are now the most competitive in the United States today. We've got 12 residents, 4 interns, and plenty of employees. So it's a busy place, very exciting, an amazing spirit of esprit de corps and a sense of family associated with this overall effort. Next slide. So recognition obviously has a subjective element to it, but it is nice to be recognized by your peers. We're in Salt Lake City. For many of the individuals in the country, that's well known as flyover country. That means that that's where people on both coasts fly over and say, I wonder who lives down there. We have to work a little harder in order to get recognition, but this is a nice survey because it represents the chairs of ophthalmology. So these are the leaders of all of the academic programs in the United States and Canada. And it is a peer survey in which they say, what do they think are the strongest programs in the country in association with these areas? This would be about 130 programs in the country. In this last year, they ranked us as 8th overall, 10th in research, 6th in regards to our residency, 9th is a clinical program. And because most of these programs are associated with the coasts, I think that means we have to be in better in that. So we do have good recognition of the quality of the work we're doing and what's ongoing. Next slide. Doximity is another way. So this would be a survey of anyone who's an ophthalmologist in Doximity can rate us, and they've ranked our residency as number 9th. So another recognition from a different source with over 315,000 peer nominations associated with this, and number 2 in the Western region and associated with our overall residency education. We have an amazing residency program, an amazing residents, and we're able to select the very, very best of the best. So much so that I joke, even though I thought I was a very good medical student, I said, I don't think I could match into my own program. It is so competitive. We will often have well over 100 applicants for every slot we have available, and then we'll match within our top 10. So that just gives you an idea of how competitive it is and what an amazing training program we've put together. Next slide, please. I apologize for that. Let's get the slide over that. That out in silence. U.S. News and World Report last year ranked us 13th, I mean, in the nation. This one is I have a little problem with, because so much of this has to do with who you can get to vote for you, who are your former graduates. And so those who have huge graduate programs for the last 50 years tend to do better. But we haven't seen this year's result, but we were ranked 13th by them the last year. Next slide. This is probably the Swedish recognition we've had. Let me tell you a little bit about this. So The Ophthalmologist is a journal that comes out of London, England. And so they like to get a group together in London, and they rank who they consider the top 100 movers and shakers in the field of ophthalmology. And this includes people in industry, in research, in clinical care, really in all elements of what's ongoing. No surprise being London that generally the British groups, Oxford, Cambridge, and in London themselves tend to get, more recognition than most of the others. About half in the United States, half in Europe, and as mentioned, a lot of industry people as well. But they recognized in this power list 5 of our individuals as the people they thought were the important movers and shakers in the world of ophthalmology today. And only Wills Eye Hospital, who has many, many times our size, had a few more than this. This is more people who gave this recognition to the Moran Eye Center than all of Texas, most of California. So anyway, we are getting noticed, and the work we're doing, people are recognizing that we are definitely on the cutting edge. Next slide. So all of that is essentially the paid advertisement, but you have to sit through now to get the real meat of this conversation in this discussion, and that's my good friend, Greg Hageman. So Greg and I go way back. I've known of his work for a long period of time, and he has been well recognized as the innovative leader in regards to making and understanding macular degeneration. There's just not enough time to tell you about how he got started in this. And one of his big strengths is that he didn't accept what everybody accepted as what macular degeneration was. And so he tried to change the mold. He tried to help people understand, with huge resistance from organized medicine. So much so, his first grant, the National Eye Institute, the head of the National Eye Institute told him he was wasting his time, that his thought that the immune system, our ability to fight infection, and et cetera, had anything to do with macular degeneration is so crazy that don't even bother trying to apply. And that's now considered one of the biggest breakthroughs, and he'll talk about that more. It took me 3 years to recruit him. I was committed that we were going to make a difference in this disease. And let me tell you as a clinician why that's so important. So just think, if you are there and your whole focus as a clinician is to try to care for patients, and one of the most important diseases you run into day in and day out is macular degeneration, and the stock line is all that was available is, yep, you've got macular degeneration, you're going blind, and there's not a thing I can do about it. Just imagine how discouraging it has to be over thousands and thousands of times. So everywhere I asked, everywhere I talked, and people said, and I said, who do you think's doing the most innovative work in macular degeneration today? There'd be several numbers, but Greg's always came on the list, and usually number one. So he and I went through this long process about how we thought we could do it better and do it differently and a whole different approach. And after 3 years of patrolling, it was the single largest recruitment that the University of Utah had done in bringing Greg here, and the work he's done here is absolutely stupendous. He's won multiple awards, as you can see. He's recognized as one of the 100 movers and shakers, and the only one associated with this, with his clear focus on macular degeneration. So this is well recognized by many people. But what I loved about Greg, and I think my parting comment about him, is that when I talked to him, I said, Greg, you know, you've got this, what do you want to do? What is the key thing you have left you want to do? He got really serious. He focused, looked in the eyes, and he said, Randy, I want to cure macular degeneration. I thought, whoa, this is somebody we definitely need to get and have and be in charge of this program. So with that, I bring you my good friend, incredibly innovative, and someone who is passionate about doing something about this awful disease. Greg, take it away.
Next slide, please. Thank you, Randy, for those wonderful comments. You're such a good friend, and I have loved working with you. Very fond hello to all of you in the audience. I do wish I could see all your faces. I think this is the first time I've talked to this many people without seeing their faces. But I do want to convey to all of you how grateful the university and the Moran Eye Center are for all of your support of the university and the Moran. I'm excited to take the next 20 minutes and tell you about our efforts at the Moran Eye Center to develop therapies for this just horrid disease called age-related macular degeneration. Next slide. So let me start with a very staggering statistic. One North American becomes legally blind every 11 minutes. And the largest proportion of these blindnesses are due to age-related macular degeneration, which is really the leading cause of what I call irreversible blindness in individuals over the age of 55. Next. So the terminology age-related macular degeneration, let me take a minute with that. Age-related because the disease, as I said, occurs primarily in individuals over the age of 55. Macular degeneration refers to the degeneration of a very important part of your retina, which is depicted with an arrow in the left-hand figure. This region is called the macula. It sits directly back in your visual axis. And as you can see in the middle diagrams, the macula is very highly specialized, both structurally and functionally. And really at the end of the day, subserves your ability to see fine detail. And it's the degeneration of that macular region that leads to the blindness associated with this disease. Now, I want to draw your attention to the histological picture on the right-hand side of your screen. This is a region of a human macula, and I want to really focus in on three structures that I want you to try to kind of focus on throughout the rest of the talk. The area highlighted in yellow is a very specialized region of the retina called the pigment epithelium, or I'll call it the RPE. That very important layer, I think, really is at the crux of this disease. And it separates the retina, which is lying below the RPE in this particular photograph, from the choroid, which is lying above the RPE. And the choroid subserves most of the vascular supply for the back of the eye. Next. So in my way of thinking, I like to talk about the disease as early stage or late stage. In many individuals with the disease, many individuals will develop these abnormal deposits, which are shown in fundus photograph, so a picture of your macula in the upper left. These abnormal deposits occur behind the RPE, which you can see in the diagram in the lower left, and they begin to distort the macular function. Many individuals with early stage disease progress to one of two very specific forms of late stage disease. One shown in the upper right is called neovascular or wet disease. In this particular form of disease, blood vessels grow into the macula, they bleed and they destroy macular function. Another form of late stage disease is often referred to as geographic atrophy or dry AMD. In this particular form of the disease, the RPE and retina die without the presence of these invading neovascular membranes. Next slide. So I think it's really the personal consequences of this disease that have been unacceptable to me and that have driven me for 30 years to really try to find a cure for the disease.
What happens if you've let your kidney disease go way, way, way too long?
So patients with this disease exhibit terrible symptoms of anxiety, loss of independence, depression, isolation, and even visual hallucinations. And like Randy said, it's not a day goes by that we don't have to deal with these individuals, and it's very sad. Facts are that 30 to 40 million individuals in the US have macular degeneration, 196 million worldwide. There are treatments for the late stage wet form of the disease, but they're very limited in scope and efficacy. And I think the biggie is that there are no treatments for either early stage disease or geographic atrophy. Next slide. So as Randy said, he and I talked a lot about 15 years ago, and he convinced me that we could create a center here at the University of Utah to really focus on the development of therapies for macular degeneration. And it's been the most wonderful 11 years of my career. If I look back, and we've made great strides in understanding the disease, but it's really due to two things. It's due to a lot of wonderful people and to a very unprecedented set of resources that we've developed over the last 30 years. So clearly Randy's leadership and that leadership of the university has been instrumental. All of you who are out listening to this lecture have supported us in so many ways. Financially, you've been volunteers for our studies. You've had to make the hard decision to donate loved ones' eyes at the time of their death. And we are grateful for all of you. I think in addition, we have built resources which include a very comprehensive set of patient cohorts with over 60,000 participants and a very unique donor eye program. And we now have a repository comprised of over 8,500 pairs of eyes. So these resources really have allowed us to understand the biology of the disease. We also created in 2011 a company called Voyant Biotherapeutics with the sole purpose of enabling the transition of our discoveries in the Center for Translational Medicine to commercialization. Next. I can't say enough about the teams and the people. Very critical. The Center for Translational Medicine has 5 full-time faculty members. We have 7 adjunct professors from all over the world, and we have this incredible group of talented scientists and clinicians, which numbers somewhere over 30. On the Voyant side, it's been my great privilege to work with 5 spectacular colleagues and friends who, I guess at the end of the day, have taught me more about drug development than I ever wanted to know, but incredible group of talented individuals. Next slide. Next slide. So let me go back in history a little bit. We started 30 years ago with a very simple scientific question, and that was, Can these drusen deposits, these abnormal deposits, teach us anything about the biology of AMD? And after probably 15 years of hard work, we learned that the drusen deposits, and these aren't unlike abnormal deposits in the brain or your arteries, they contain a host of proteins that are associated with overactivation. And I really want to concentrate on that word overactivation of a very important component of your immune system called the complement system. And it was really this discovery of complement overactivation that led us in the early 2000s to discover the first genetic association with macular degeneration. And that association is with a gene called complement factor H, a key regulator of activation of complement. So the risk form of complement factor H does not work very well and does not regulate complement as well as it should in the body. Next slide. So one gene, complement factor H on chromosome 1, a second major genetic locus was identified in 2006 on chromosome 10, a pair of genes called ARMS2 and HTRA1. But the take-home message for all of you is we've been able to show very nicely that the risk alleles, the risk genes on chromosomes 1 and 10 account for over 80 or over 90% of all risk for developing macular degeneration. So this gives me great hope that with a limited number of therapeutics, we can certainly treat a very large number of individuals. Next slide. We've also learned over the last 10 years in looking at the specific contributions of chromosome 1 and chromosome 10 to the etiology of macular degeneration, we've learned that macular degeneration really is two very distinctly different diseases. And that's a very important issue when you think about developing therapeutics. It also means that individuals, many individuals will have both diseases, and down the line will really require multiple drugs to treat multiple diseases. Next. Just an example here, you're looking at the maculas of an individual with chromosome 1 directed AMD in your upper right and chromosome 10 directed AMD in your lower right. And it's very noticeable that there are distinct differences in the macula. Chromosome 1 is really characterized by these large drusen pigment epithelial detachments that you can see. They look like little blisters there in the macula. Chromosome 10, on the other hand, not very much associated with drusen, but associated with very abnormal retinal vasculature. Next. And I think exciting for me, and another piece of information that has really taught us that macular degeneration is two different diseases, are the systemic co-segregating diseases. And we've learned that chromosome 1 and 10 drive very different systemic diseases, in addition to driving very different ocular diseases. Most recently, just as an aside, we've spent a lot of time in the last couple of months and have some very strong data to support that chromosome 1 and 10 may indeed be associated with the severity of COVID infections. Next. Next. So let me talk about a little bit about therapeutic considerations. I've watched a lot of trials in macular degeneration, particularly over the last 5-7 years, fail, and I think largely because they have not addressed the biology of the disease in an appropriate fashion. And that's where we have a heads up. We have these wonderful resources at our disposal. But it's very important to know what pathway you want to target with your drug, what target within that pathway you need to target, where that target is located, the concentration, and then you need to decide really what's the appropriate therapeutic agent that you need to use. And in a disease like macular degeneration, we need a therapy that's going to last for 30, 40, 50 years, maybe even some cases. You then have to really think a lot about delivery mechanisms, and of course, down the line, important that you have appropriate clinical trial or clinical treatment endpoints. Next, please. So I told you that risk alleles of the factor H gene are highly associated with the development of AMD. And as most of you probably know, we all carry 2 copies of every gene. So if you carry 2 risk copies of the factor H gene, you are at very high risk for developing the disease. What I didn't tell you is that we've identified some very highly protective forms of the gene. And if you carry 2 copies of the protective forms, you are very unlikely to develop the disease. Now, a very important observation to our therapeutic strategy has been the observation that if you carry 1 risk allele and 1 protective allele, you are highly protected, suggesting that all we need to do is give individuals who are making the risk form of the protein some protective form to reverse or slow down the manifestations of risk. Next. So I told you that complement is overactivated at that interface between the RPE and the choroid. And the really bad player in all of this complement overactivation is a group of proteins called the membrane attack complex, shown here in green, and in an individual donor who carried chromosome 1 risk on the top and chromosome 1 protection on the bottom picture. And you can appreciate the fact that there's a lot of this membrane attack complex at that RPE choroid interface in individuals who are developing macular degeneration. That membrane attack complex intercalates or into the RPE and other cell membranes and literally kills cells. And the problem with killing the RPE is really that it has no capacity to replace itself. So once it's dead, it's dead. And that is probably the driving pathology for this disease. Next. And you can see here again, these are sections of 2 human maculas, the one on top from a protected donor, the one on the bottom from a donor that carries factor H risk. I've put yellow arrows on that very important RPE layer, and you can see in the lower image that the RPE, because of all this overactivation of complement, detaches from the back layers of the eye, from the choroid, and you can actually see these large pigment epithelial detachments, we call them, but they're actually like large blisters. Next slide. You can see the same thing in this patient over a period of 2 years. The top image again shows the development of those RPE detachments. You can visualize those as large blisters, if you will, in the orange fundus images to the left, and also in the cross-section image to the right. As that RPE detaches, it begins to die, and the underlying retina is also lost, and you develop a large area of atrophy in the macula, which I think you can appreciate best in the 2 lower left images, where the macula is essentially gone. And this individual would be technically blind. Next. So how do we tip the balance in patients? What is our therapy of choice? We know from some of the things that I've told you that all we really have to do is tip the balance of complement regulation from risk towards protection. And we are doing that by delivering the protective form of the protein to the RPE, and that's very important, using gene therapy. So next slide. So to make gene therapy a bit simplified, one wants to take their gene of choice, which in our case is protective factor H, and we want to package that gene, first synthesize it, and then package it into a virus that's called AAV2, a much nicer virus than the one we've all been dealing with for the last months. This virus does not have any capacity to replicate itself. The virus then is injected into the eye, close to the RPE, as close to the RPE as possible. It will infect the RPE, and the protective factor H gene will produce protective factor H. Next. And so we're currently examining ways to deliver the virus. So we've made commercial virus at this point. We're trying to figure out the best way to deliver that virus to the RPE with the less insult to the retina. We've have experiments in progress to look at injecting the virus with a syringe into the middle of the eye, and that's shown in the lower left figure, hoping that that virus then can cross the retina and infect the RPE. We're also trying to introduce the virus to the choroid, which is shown in the middle figure, again, hoping that that virus will make its way to the RPE. The third technique we've been examining is much more difficult and involves a lot of surgery, but it involves injecting a needle through the retina and delivering virus to the space between the RPE and the retina. Next. And these are some examples from non-human primates. So our virus is doing its job very, very wonderfully. We're still trying to figure out what the best delivery mode is. But in these two images, anything you see in a bright pink color means that the virus has infected those cells and is making protective factor H. And you can certainly appreciate in the high magnification image to the right that the RPE, that single layer of very important cells, a lot of those cells are bright pink, which means that they have been infected and they're making a lot of truncated or protective factor H. Next. Next. So let me just end by talking a little bit about our current clinical strategy. We have spent a lot of time over the last 10 years, and we are continuing to follow a large number of patients, both at the Moran and the National Eye Institute, following somewhere in over 5,000 patients, which is very important to identify the exact progression of the disease so that we can develop appropriate clinical trials for looking at efficacy of our drug. Our commercial product that has been generated will be tested in non-human primates for safety, large toxicology studies. Once that's completed, we will go into what's called a phase 1 study, somewhere in the neighborhood of 12 to 18 patients, really with the goal of assessing the safety of our drug. Assuming that the phase 1 study goes well, next, we will move to phase 2 and phase 3 studies, which we're currently in the process of assessing how best to conduct those trials. Next. So let me just leave you with a couple of take-home messages. I hope you go home with the notion that greater than 90% of all risk for developing AMD can be explained by genetic variants in genes located within chromosome 1 and chromosome 10. Importantly, AMD is two very distinct biological diseases, both within the eye and also in the systemic system. So very specific co-segregating systemic diseases, which really suggests that any drug we might develop for the ocular manifestations of the disease might be applied to some of these very large co-segregating diseases. I hope you've learned a little bit about the complement system. It's really overactivation of the system at the level of the RPE choroid interface that causes death of the RPE and other cells and leads to that degeneration of the macula that characterizes the disease. We strongly believe that the use of the delivery of protective factor H to the RPE should restore this overactivation at that interface and reverse or greatly slow the process of the disease. And I think it's a wonderful example of personalized medicine. Of course, the first clinical trials will be conducted only in patients that carry risk at chromosome 10 or chromosome 1. We strongly are strongly behind in our understanding, or shortly behind in our understanding of chromosome 10, and we anticipate thinking about therapies for that disease in the very near future. So we hope to initiate a phase 1 human clinical trial for chromosome 1 disease, hopefully by Q3 of 2021. Next slide. And I'll end with a heartfelt thank you to all of you out there who are participating in this lecture and who do so very much to help both the university and the Moran in their efforts to develop therapies for macular degeneration. So thank you very much for your attention.
Dr. Olson and Dr. Hageman, thank you so much. If you haven't done so already, please submit questions via the YouTube chat or send them to clubs@alumni.utah.edu. Okay, so starting off, during COVID, do you recommend patients with AMD stay at home if all is going well, rather than venture out to the specialist for an annual checkup?
So this is, I'll take that on, Dr. Olson here. What we have, because it is important that you have the disease followed, and there are complications that are treatable that may not be apparent to the patient, and if you wait too long, it can cause permanent damage. We also know that our macular degeneration patients, by and large, are those that are over the age of 65, so that they're at increased risk. So what we've done at all of our centers is emphasis on safety. And I could go on a long time about how we've thought about this. Simple such things as everybody has scrubs. They don't wear a lab coat or anything, could potentially be used more than one day. Fresh scrubs every day. Washing everything down. I think anybody who's been to our place will know how we're bending over backwards. I don't think there is any substantial risk. We're not aware of a single patient in whom this disease has been passed on by a visit to the Moran Eye Center. So I think it's safe. I don't think that we'd want you to come in necessarily, but for somebody with macular degeneration, and people should be seen annually, and I'd recommend that you do that, and we'll commit to you that we are bending over backwards to see that experience is as safe as it possibly can be, and I think the risk is much less than going into a grocery store or something.
Is AMD hereditary?
So Greg, you handle that one, and I'll, yeah.
It's absolutely 100% hereditary. So not to say, and really, as I said, two major genes, one on chromosome 1, one on chromosome 10. It's the combination of those genes that fluctuate in families a bit. So it's not as simple as every one of your children will develop macular degeneration if you had macular degeneration. All of that being said, there are some influences from environment. Largely influences like smoking will exacerbate the disease, but not by any significant amount.
Let's see. Are there any dietary or exercise recommendations to mitigate macular degeneration? What about over-the-counter medicine, vitamins, or supplements?
So I'll take that one on. And there is a lot of work that's been done in this area. And so let me start out by saying that there is impact. So all of us are partially, nature, which would be our genetics, and nurture, which is what we do in our lifetime. Some diseases, nurture, what we do in our life is way more important than the nature. This is one where nature is really important, as Dr. Hageman has just pointed out. But what has been shown to be helpful, and it's more helpful the less your genetic risk. Mind you, there's many different variations. There's a beautiful slide that if Greg had it to show you what the overall risk of losing vision is depending upon your genetic background. And each one of these, whether you have all 4 bad genes or just one of them or 2 or 3 and the rest, or you get protective, each one of these is a distinctly different overall progression and likelihood of losing vision. But the things that we do know that there have been studies that show that those who regularly exercise slow down their overall risk, slow down, and that seems to be true about everything we do these days. Everyone, couch potatoes, we just don't win. I happen to be a big exerciser myself, but exercise, regular aerobic exercise has been shown to certainly have a protective effect. And again, the less your genetic risk, probably the more important that is. And diet, and it looks, and every study done so far shows lots of leafy green vegetables, and particularly things like, kale, arugula, all of that, broccoli, in that old cruciferous category, fish, whole nuts. Those are good for us anyway, so you don't lose in any of that, right? I mean, that's good. Fruits and vegetables in general. And so that's always a smart thing to do. And then there has been this one specific vitamin combination called AREDS, and now it's an AREDS 2. And it's got some minerals and vitamins, and there was a small but significant difference when it was utilized. And so we do recommend that. I don't want anybody to think that any of that's a panacea, sadly. But if you've got it, those are certainly things that you should do. And as far as the exercise and diet, that's something we all should be doing anyway.
What are your thoughts on screen time? So laptops, phones, devices, any way to mitigate potential damage to the eyes?
Greg, if you've got something, I'm not aware that any of that, our eyes, fortunately, generally don't wear out. I'm sure that there's some limit where maybe with this disease, but by and large, if you're functioning okay with your eyes, you can go ahead and use it, and no evidence that I'm aware of that this exacerbates, the underlying genetic risk, or whether you're going to get macular degeneration. Greg, are you anywhere of any study that suggests that use itself
No.
accelerates your loss of vision with macular degeneration?
No strong data that I'm aware of, Randy. I mean, that being said, I would encourage folks to wear their dark glasses when outside.
Sure. No reason not to add aggravating ultraviolet light and others on top of what's already there.
So can you comment on the Lucentis port delivery system and its validity relative to other methods of improving ocular half-life? So polymer conjunctives, and then alternative therapies such as gene therapy.
Sure, I can take that one. We've seen a transition in treatments. So the treatment for the wet form of the disease has largely been, or was initially injections in the eye as much as every month. That was followed by some of these slow release delivery systems. So the new Lucentis system, I think probably with a single dose will last for up to 6 months. It's a refillable device. It's very wonderfully designed. And it also allows, at the time of refilling the device, that scientists can look at the turnover of Lucentis in the eye. I think the next phase in our development, and it's ongoing now, would be the delivery of these anti-VEGF drugs with gene therapy. And in theory, a single dose of gene therapy should last you for many, many years.
Let me just add to that this is a complication that can happen both with chromosome 1 and 10, where you get upregulation of a hormone that causes abnormal vessels to form, it's VEGF. And so these things will then block that. And it represents somewhere between 10 to 15% of those with macular degeneration that could have this particular risk. there is underlying dry macular degeneration anyway. And the hope we have with what Dr. Hageman, the group, is doing, that we block it at the very basal level. And if we block the macular degeneration, then the wet will not be there. So we're looking at the actual underlying cause of macular degeneration rather than that subset who gets this wet, as they call it, in which they have to have the injections or treatments.
Can anyone enroll in your study? And if they are interested, how do you go about doing that?
So I would encourage anybody that is willing to participate to do so. It's tremendously helpful to us. Probably the best way, Brooke, is to send everyone a contact number that they can call for the SCTM. And we're happy to see anybody of any age group with or without the disease. All study patients are incredibly important to the research.
And we will include that in the follow-up email. So if you are interested, you can call that number. Dr. Olson, were you going to say something?
Some people might say, well, wait a minute, I don't have it in my family history, and I'm not aware of anybody in my family has. Why would I be important? It is critically important for us to be able to compare those with macular degeneration versus those who do not have macular degeneration. In particular, those with no macular degeneration over the age of 80 is a group that's been particularly helpful for us to look at. You know, what is different, and looking at why that is, and further understanding the genetics of all of this. So yeah, no, people, please be involved. You're helping everybody by doing it.
And I should mention, Brooke, that there's no cost involved, and a very thorough eye exam. So.
What is the average age of onset for age-related macular degeneration, and what are the first signs?
So I can take that. So the average age is I would say in the early 70s for chromosome 1 disease, probably somewhat earlier for chromosome 10 disease. The patients that actually have risk at both of those genes, we see quite a few patients in their 40s with, so again, as Randy said, it depends on the dose of risk genes that you carry. And it's probably valuable if you have a family history to know what your potential risk is. But the first signs for chromosome 1, as I said, are these deposits of drusen back behind the macula. Chromosome 10 is much more difficult on its own. And I think that's another reason why understanding your genetics is potentially valuable. The chromosome 10 people very often go to late stage disease without any real indication that they had the disease in the first place.
Let me just add that to that the signs of the disease are apparent most of the time. Chromosome 10 is the one that, as a clinician, I've gotten better at looking for what the subtle signs that can be there, but you can see the disease usually before the patient has any visual complaint. And you like to catch it early. You like to, be aware, doing everything you can. So that's part of the reason why routine eye exams are very important. Try to catch it. If the patient hasn't been seen regularly, what I often see happen is the patient will complain that, they've tried to change their glasses 4 times, but it's just not clear. Their vision just is blurry, and they don't know why it's blurry. More often than not, that's due to early cataract formation, but it's surprising how often we'll see definite macular degeneration, and that's definitely starting to degrade the quality of the vision.
23andMe includes a test for alleles causing AMD. Are you familiar with those? And if so, how do they connect to chromosome 1 and 10 and the specific allele you talked about? Are there other ways to find out if you carry a protective gene copy?
Yeah, so interestingly, and it may have changed by now, but I have talked with 23andMe. They're very good at assessing your risk at chromosome 1 and 10, but they have done a very poor job because they don't understand these protective associations. So as I said, you could tell somebody that they carry a risk allele at chromosome 1 and they have high risk. But if the second allele is protective, they're actually protected. And that's not reflected in the 23andMe testing.
That's my experience too, that I've had patients that are really freaking out, and I look at the results. So let's check you again, because they don't show that protect. We find they're protected. So really, you're not at risk. So I would be a little leery. I think in general they do a good job, but I've found the same thing, that often they'll overemphasize the risk when it actually is not there.
So is there a way to identify if you have a protective gene?
Probably the best way is to join our study. So
That's done for free. we do it on everybody.
There's no commercial effort that I'm aware of that tests for protection.
So how does one form of AMD morph into the other form, and why does it occur if there are two distinct diseases?
So, this issue of the traditional view that, there's this progression is probably not very accurate, right? Again, it's the mixture of risk and protective alleles that one carries that determines what that disease progression will look like. So there's no straightforward answer to that without a knowledge of your underlying genetics.
Let me add that when people say, yeah, there's two types, is, yeah, we get that there's dry and there's wet, right? That's what we hear that all the time. I said, no. So in chromosome 1, at least my thinking of this as a clinician, and Greg, if you want to give greater insight, certainly pass it on, is that in 1, what's happening is that you are killing off tissue through this underregulated and too much complement. And one of the body's responses to tissue dying is it's trying to repair. And so you get too much of this VEGF, which is saying, get vessels, build, fix, and they just don't work there, and they leak and they bleed, and that's what we call wet macular degeneration. In chromosome 10, the problem is a different one, and often I think you're at the point where you're not getting enough blood to that area, particularly from where most of it has to come, and that's from the choroid. And so you get to a certain point where it's saying, we need more blood, we need more nutrients, we need more oxygen, and then it upregulates. So it's totally different reasons for the two, but the outcome is the same. Is that too simplistic, Greg, or is that pretty?
No, I think the only thing I would add is that we talk about neovascular or wet disease. There are actually 4 very different biological forms of that wet disease. Some of which are more prevalent in chromosome 10 and some of which are more prevalent in chromosome 1. So, wet disease is not wet disease across the board.
And I got to do a shout out for Greg and his team. Greg was able to recruit 2 amazing researchers from Germany, a husband-wife team. And they've done some landmark work showing that there are actually some of these forms of so-called wet macular degeneration, which is actually protective. It's best to leave it alone. And so we're learning a lot about this, and it's exciting to have this dynamic duo help us, further understand the clinical course of this disease.
Quite a few people asked if there's a possibility in the future that treatments would progress and eliminate the need for eye injections. Is that possible?
That's really our foremost goal, to treat the disease early so that you don't develop the late stage forms of the disease. Of course, because of requirements for clinical trials, that's not immediately addressable. But I think down as we get into secondary phase 2s and phase 3 studies, we will try to treat the disease earlier and earlier based on your genetics.
It's the whole point of Greg's work is that no, we don't get to the wet macular degeneration. We don't get to the point where they have to be, that we stop the process at an early phase and save the vision. That's the dream.
Sorry, keep going.
And the hope.
You mentioned AMD in relation to COVID-19. Does COVID exacerbate the disease? Can you talk a little bit more about that?
So there is no data that suggests that COVID exacerbates the disease process in the eye. So I think that's pretty clear. There was a study that published in the UK a couple of weeks ago that suggests that patients with macular degeneration were highly represented in COVID patients with severe disease. So, and that's an angle that we've been looking at here at the U for the last couple of months. And I think we will find that both chromosome 1 and 10 are exacerbating COVID severity, but the other way around does not appear to be true.
So the risk for macular degeneration could also be a risk for having a bad outcome with COVID, and Dr. Hegeman's group are doing an amazing job to dig into that. We hope to get information of more detail in very short order on that.
So to kind of close, Dr. Olson mentioned at the beginning that Dr. Hageman, your goal when you started was to cure AMD. Where do you think you're at in that goal? And can you tell us maybe when you might have a cure for AMD? Well,
I can tell you that I'm so excited and I am so proud of the individuals that really do the heavy lifting. The teams that I work with are just amazing. I think there's real hope. I think we will learn next year whether our first therapeutic is going to work or not. And going from 30 years ago when we just had a simple question about drusen to actually thinking about putting drugs into a human is very exciting. And I'm very excited for all the patients that we see that struggle with this terrible disease.
Well, Dr. Olson and Dr. Hageman, thank you so much for your incredible presentations and just telling us a lot more about AMD, and thank you. We really appreciate it. And I want to thank everyone else that joined us this evening. We look forward to seeing you on Wednesday, August 12th with Doug Fabrizio, who's the host and executive producer of KUER's Radio West. We hope you have a wonderful evening. Good night.